All right. Well, welcome to the most recent episode, this most recent episode of the Akkad and Coco Report. We have Michelle in San Francisco as always, and I'm in Philadelphia. And today we have the pleasure of having Dr. Milton Packer. Dr. Packer is an internationally recognized clinical investigator who's made many seminal contributions to the field of heart failure. His work spans nearly 40 years and has been strongly supported by a number of investigator-initiated grants from NIH and from industry. He's widely recognized for his outstanding leadership. He's led the Division of Circulatory Physiology at Columbia University for 12 years. He's also served as a member of government advisory committees, data safety monitoring boards. He worked in the FDA. He's been president of the Heart Failure Society of America for 2000 to 2002. He spent most of his career in New York City at Columbia University, and then most recently, I believe until from 2004 until 2015, he was professor and chair of the Department of Clinical Sciences at the University of Texas Southwestern Medical Center of Dallas, and he's currently at Baylor University Medical Center. He came to our attention because he writes for MedPage, and he has written a number of very interesting blogs. And the one that particularly caught our attention that we want to focus on is his view on academic medicine. Welcome, Dr. Packer. Thank you so much for coming on.
I'm delighted to be here. It's great to join you.
So we'll start. I wanted to give you an opportunity to tell us what you wrote about, and you had a very nice kind of historical overview of how medical schools have evolved. So can you tell us, so starting, in the 1800s, I'll start you off. In the 1800s, there were, a number of different medical schools. Some were these small proprietary schools that operated for profit, weren't affiliated with universities, and things were fairly variable in terms of what education folks were getting at these various different places. And then someone at least happened. So can you tell us what happened?
Probably the best way to tell the story is that I think we've had three main, what might be called phases of medical schools. And let me make sure that everyone understands that for most of the time that the United States was in existence, there were lots of medical schools. They were really small. They generally had only a dozen medical students. They were typically affiliated with one physician or a group of physicians. It was more of what might be called an apprenticeship than it was an academic education. And these little tiny schools were for profit. They weren't affiliated with universities. Frankly speaking, it's impossible to know exactly what people learned at the time. And it would be fair to say that most physicians came out of the experience poorly trained and really didn't know very much. And so there was a consensus at the end of the 19th century that things were not going well and that we didn't have standards and that medical schools needed standards. And because if they didn't have standards, then the public wouldn't trust physicians. And the seminal event that occurred was in around 1910 when Abraham Flexner issued a report on the state of medical schools and made some very specific, powerful recommendations about what medical schools ought to be, how they should function, how they should be organized, and what their business model should be. And he thought about this for a long time. And what people may or may not realize is that that report, the Flexner report, was the event that changed American education. The whole idea of the Flexner report was to make American medical schools similar to European medical schools, because American medical schools were a mess. European medical schools were academic experiences, and Flexner wanted to do a better job. So he proposed a number of things that may sound very familiar right now, but at the time that he proposed them, they were revolutionary. The first thing he proposed was that if you went to medical school, you had to go to a college or university beforehand, and you had to study basic science, and you had to be trained in a scientific manner. And you had to take specific coursework in order to understand the biology and physiology of the human body in order to be a physician. There was a big emphasis on, at that time, what was called basic science. Of course, at that time, basic science was nothing of what we call basic science now, but it was a scientific manner. And he said that medical schools, in order to implement this, had to have full-time faculty. And that created a little bit of a problem, because Flexner couldn't really figure out how these full-time faculty would be paid. Because if he counted up the number of full-time faculty that were needed in order to teach all these courses, there were too many.
Right.
And no matter how many medical schools you had, the tuition would never be big enough in order to support the faculty. And it was particularly true because his principle was that anyone who was full-time faculty shouldn't be in private practice. They should only see patients who were what he referred a charity practice, that they would never bill for their services. They would be role models. They would dominate hospital services.
Right.
And he had the problem.
Right. So implementation of the Flexner model had some good things with it, which, there were some substandard medical schools that existed, giving out, essentially there were, certificate stamping operations, and that the Flexner report ended up shuttering many of those. But as you're pointing out, the problem was, well, okay, now that you have, who's going to pay for this? These robust medical schools that require faculty. So what happened to the composition of medical schools after the Flexner report?
Well, the medical schools, most
in terms of the students, I'm asking. So
most of the medical schools shut down.
Right.
The number of medical schools shrunk by about 70-80%. Only the academic medical schools survived, but the medical school faculty was small, and the question that arose was, how do you pay for full-time faculty?
Right.
And for most of the 1940s and 1950s, it wasn't a big problem because there weren't that many medical schools, there weren't that many students, and in fact, that is what was so interesting. What people don't realize is that the Flexner report essentially created a medical monopoly. That because the number of medical schools shrunk and the number of graduating physicians decreased, that the number of people who could call themselves doctors plummeted. And now there were so few of them, and they were so well trained that they now had a monopoly on the market. They could command whatever prices anyone would want to pay, and people respected them. People said, "Oh my God, you're a physician. You've gone to school for all this period of time. You must be extremely smart." And not only were they smart, but they were pretty well off. They could charge whatever they wanted to charge, and they could charge their wealthy patients so much that they could spend half of their time taking care of patients who couldn't pay. And so that what American medicine looked like was a small monopolistic group of people who had a lot of community respect and who charged the rich in order so they could care for the poor.
Yeah.
And that was what medicine was like in the 1940s, 1950s. Physicians were worshipped, and they had a pretty good situation, but there was a problem. And the problem was that there weren't enough physicians. And if you were going to build more medical schools and you wanted to have more courses, you needed more faculty. And the question is, where was the money going to come from? So
let me interrupt here. This is
Sure.
a wonderful history, and I'm sort of in full agreement with the facts. I just want to clarify that in the aftermath of the Flexner report, what happened is licensing laws were passed.
That's right.
Connecting the granting of a degree by the state, medical state boards, to graduating from an approved medical school that had the curriculum that Flexner had recommended.
That's exactly right.
Right.
And so the medical board said in order to be licensed in the state, you had to have a degree from an approved medical school. The degrees were very hard to obtain. And the reason that, and that's why I call it a monopoly.
That's right.
Physicians had a monopoly on healthcare. They limited the number of people who could call themselves physicians, and they got the state boards to agree with that plan.
Right. So the beginning
right.
of the state-granted monopoly for physicians, and this was certainly good for physicians, as you're pointing out. But medical schools,
it was at that time.
Yeah, but medical schools still had a problem, and of course the nation didn't have enough physicians. But again, the state rode to the rescue in the 50s, 60s, and 70s, and you point out that there were a couple of different things that happened. The one thing that you mentioned that happened was that we started funding the NIH at a much more significant level. Those NIH funds, millions of dollars, started flowing into medical schools for research, and of course, in 1965, Medicare came to be, and now you had another large pool of money that could be accessed. So those two things now came to be. So that's, you would say, the second or third phase of medical education. What changed at that point? Was that a
so
better?
Now I'll call it phase two.
Yeah.
Phase two, the medical schools were flooded with money. They were flooded with money from the NIH. They were flooded from money from Medicare and other healthcare services. And all of a sudden, it became possible for physicians to actually support themselves through revenues that had nothing to do with tuition. The Flexner model always recognized tuition was never going to make it. And so in the 1950s, 60s, 70s, the government came in and said, we're going to take care of the medical schools. We're going to take care of the faculty. And the medical schools grew enormously. They went from having a handful of faculty to hundreds thousands of faculty. And they could all support themselves through research grants, through seeing patients in the private sector. Essentially, the government flooded medical schools with funds. The medical schools grew. The medical schools prospered. When I went to medical school, and I subsequently went on the faculty of Mount Sinai in New York, I remember I had my first job as a instructor of medicine and head of the coronary care unit. And I was expected to do no billing.
That's amazing.
All I needed to do was come in and teach and be a role model and ensure quality care, and the hospital would support my salary, never ask questions about how I spent my hours, never ever asked how I was going to support myself. I applied for NIH grants because I was interested in research. And when the NIH money came in, I remember the chief of cardiology said, well, that's nice. You have an NIH grant, so I guess we don't have to pay you. And that's the way it was. No, there was so much funding through various sources that the medical schools could spend their time teaching, they could spend their time as role models, and they could spend an enormous amount of time with patients.
So what happened to kind of end this era?
Well, what happened was in the 1980s, medical schools got so big that they needed more money. And they kept on hiring people. There weren't enough NIH grants. So they kept on telling physicians, well, now, if you want to be paid, you need to generate your revenues. And the biggest change occurred when in the 1970s and 1980s, there used to be a major disconnect between the salaries of academic physicians and salaries of physicians in the private sector. It would be very common for physicians in the private sector to make 3-4 times as much as what people made in academic medicine. But the academic physicians said, well, we don't want to be paid so little. We want to be paid for the same as our colleagues in the private sector.
Right. And that money that the private sector doctors were making at the time was primarily because Medicare was very generous and insurance companies were they were paying without any regards to what was being delivered or how much was being charged and so forth, right? It was
that's right.
There was
no oversight. Basically, if the physicians submitted the bill to insurance company, it was paid, period. Full stop. There was no approval process. If a physician did 10 procedures, they were paid for 10 procedures. If they did 500, they were paid for 500. Whatever bills the physicians were paid, submitted, were paid.
So that's the hard part to understand. So it seems that at some point you went from medical schools that were somewhat freestanding and independent and had their own teaching mission, and then somehow there was this amalgamation with the health system. How did the health system come to be, and how did suddenly the mission merge so that now the medical school was subservient to the health system? Like what happened there? I'm honestly not clear as to how exactly that happened and why that happened.
In the late 1980s and early 1990s, it meant something to be a dean of a medical school. You had resources, you made decisions, you had ability to appoint faculty, decide what an educational experience would be. You managed a major research enterprise. And a dean was a pretty important person. Chairman of departments were important people. Division chiefs were important people. I was a division chief, and I was managing a business enterprise that brought in $7-8 million a year, and had to decide, and I had total discretion as to how I would allocate those funds. I could hire as many faculty as I wanted. I could determine how people would spend their time, who would do research. And then in the late 1980s, early 1990s, the world changed. And the world changed because third-party payers said, we're not going to pay for everything a physician bills. We're going to pay only for things that we think are valuable to patients. But that issued in an era where physicians needed to document what they did, how they did it, and why it was useful. They had to be responsible for their time and their effort. And not only that, but the monies began to be funneled primarily through hospitals and not through medical schools. Hospitals became the major avenue by which the government and third-party payers channeled their resources. It was virtually impossible for physicians in the private sector to keep up with all of the documentation, all of the paperwork, and all of the bookkeeping that was required. So as a result, the hospitals took over this responsibility. They said to physicians, if you work for us, we'll take care of all the details. But if you work for us, you better work for us.
Right. So what happened was that hospitals, which had traditionally been used as staging grounds for physicians, now the hospital became the employer. And when the hospital became the employer, now the hospital is affiliated with the medical school. Now all of a sudden you have a health system with physicians as, worker bee units that are revenue producers.
That's exactly right. The hospital said, well, if you're going to work for us and we're going to pay you, and by the way, if we also take care of your malpractice and your benefits and everything else, then we want to make sure that you're spending time generating revenues on our behalf.
Right.
And that's when the health system came into place. The CEO of the health system now became the major determinant of how physicians spent their time. And so as a result, the leadership of the medical school lost control of their faculty. The faculty, they didn't pay their faculty, so the faculty really didn't have any motivation to listen to them.
The faculty either had to survive if they were very good by generating their own research grants, or by generating revenue for the health system.
That's right. And when they started working for the health system says, well, we don't really care about research. We care about revenues. And and the physician said, well, if you want us to generate revenues, you have to pay us more. And then the hospital said, okay, well, if we pay you more, then you have to generate more revenues.
Right.
And what has happened over the past 15 years, and especially over the last decade, has been this incredible self-reinforcing cycle where physicians are demanding higher salaries. The health system puts more pressure on them to generate revenues. They demand higher salaries. And as a result, the time that they spend with each patient has dwindled. And the reason is that medicine has now become a volume proposition. It has been driven by volume and by procedures.
And not to mention the time spent on teaching activities. What happens to teaching during that whole process?
No teaching. What teaching?
Right.
Who does teaching? No. I'm sorry. No one's paid to teach.
So
theoretically, you might be paid to teach if you work at a state university.
Right.
But at a private medical school, no one is paid to teach.
Right. So once the health system had control of the revenue, then everyone else in the medical school. I mean, you still have chairmen, you still have deans, you still have section chiefs, but you make the point that these are essentially figureheads. You have a beautiful paragraph here that I'm going to read. You say, as a result, many deans at modern medical schools serve a ceremonial function. Like the English monarchy, they preside at events and say inspiring things to those in attendance, but they have no power. But unlike the Queen of England, they typically have no money. And they don't televise really nice weddings either. So, what is the point?
The dean of a medical school right now is purely a figurehead. The dean controls no resources unless the dean raises money through philanthropic sources. But in the absence of philanthropic sources, or in the absence of state support at a typical, let's say, private university medical school, the dean supervises a PhD program. Now, that doesn't mean that there aren't faculty. There are hundreds and thousands of faculty, but they don't listen to the dean because the dean doesn't control what they're paid or how they spend their time. The dean doesn't control how they're rewarded. The only thing that the dean can do is be a cheerleader. But none of the faculty have to listen to their cheers. So you have a dean, and you have department chairs, and you have division chiefs who, unless they do what the hospital or the healthcare system wants, they have no meaning.
So now, is the medical school, the medical schools in terms of their mission to teach medical students, that seems relatively preserved, right? Meaning,
no. It sounds like it should.
They pay tuition, and they sit through basic science lectures, and they have clinical rotations. So that seems unchanged, or you think not?
The tuitions have become exorbitant, right?
I think it's changed. So, I think the question that you're asking is who suffers in all of this? Well, first of all, physicians have suffered because they now are employees of a revenue-driven system. They're basically working for a business, and they're business employees. The concept of professionals who are thoughtful and are patient-driven has disappeared. So patients have suffered. That's one. Physicians have suffered because of this, their morale is terrible.
Yeah.
Burnout. There's enormous pressures. They have no time to read, no time to keep up with the literature, and they suffer.
Yeah, I see this a lot in terms of the turnover. So it's not that physicians, I don't think you're saying, I think there was some criticism about whether or not, do physicians still care about their patients? And I think individually, a lot of physicians still care about patients and they're still
Of
trying to
course they
discharge
do.
responsibilities. They stay late, they do all those things. But, it's reflected in the fact that there's a tremendous amount of turnover, especially in some of the intense fields. So, I know oncology is constantly trying to recreate itself in these various divisions because, my goodness, it's a very intense area and there's a lot of pressures being placed on these folks by the health system to see patients every 15 minutes and whatnot. So it's not a healthy environment for physicians to
It's a
thrive
toxic
in.
environment.
Yeah, it's a toxic
It's a
environment.
really toxic environment. It's a toxic environment for the physician and for the patient.
Is
And I will tell you, I've gotten to an age now where I spend a fair amount of time being a patient and not just a physician. And I know how to work the system, and I still get my 13 minutes with a physician.
Yeah.
And my questions are not answered. The concept of most physicians who I see walk in, sit at a computer, look at a screen, and never look at me.
Yeah. Yeah. Well,
So
they can see the reflection sometimes. The way I have it set up in my office, I can see the reflection in the screen of the patient. So that way.
Oh, that's very good. That's nice. Yes, it's good. It does
But
does that
I was
work?
getting to the point about medical education, meaning medical education in terms of medical students. Do you think that is that at the very least is somewhat preserved?
I don't think so.
You don't think so? Okay.
So,
Why is that?
so now, remember who now teaches medical students.
Basic science faculty and
So you might say, why do basic science faculty, why do medical students sit through basic science courses? Well, the major reason is not because they need to know basic science, because they don't need to know basic science to practice medicine. They sit through basic science courses so that the funds that are available for education can be diverted to basic science faculty that do not have research grants. The same applies on the clinical side. So just think of it this way. If you're a basic science researcher who is successful and is really smart and has a lot of funding, you don't teach medical students. If you're a basic science researcher who is desperate for support, you teach medical students. If you're a clinician who is really busy and does lots of procedures and generates a lot of revenue, you don't see medical students. If you're a physician who cannot see enough patients to support their salary, you teach medical students. So medical students are being taught by individuals in basic science and in the clinical sphere that are failures at their primary mission. That is weird. That is sad.
That is terrible. That is terrible. But I want to get a sense of, let's say, Dr. Milton Packer was given the job of Abraham Flexner in the 1910s. Would he have done something different? From reading your piece, it's a little ambiguous how you feel about the Flexner reforms. Was the future baked into it, or did we go wrong somewhere? Was it a good reform? And so, what would be the ideal medical school according to Milton Packer?
Oh my God,
that's a lowball question.
It's a fair question, but it's an impossible one. Let me try to answer it in the following way. Flexner was himself a very complicated person. Essentially, what he wanted to do was take a profession and move it from being a craft profession to a elitist profession. Flexner was in every sense an elitist. He believed that if he created the highest standards, that people would meet them, and that people who met them would be considered special by society. Now, that is not right now considered to be an enlightened point of view.
Right. That's correct. Flexner, if I may add here, you're absolutely correct. He was funded by the Carnegie Foundation. The Carnegie Foundation at the time, Carnegie was already dead, but it was led by a lot of quote unquote enlightened people who really thought about, it was the heydays of science and the hope of science, and they were social engineers. And they thought that if you had these elite schools, even if you had much fewer of them, elite schools, you trained elitists, that would solve the problem. And so Flexner bought into that. And there were some academic physicians who were of that, who believed in that as well, because his brother was at Hopkins.
Yes.
Simon Flexner, and really he adopted the Hopkins curriculum, which, as you said, was a copy of the German curriculum.
That's right.
Of the late 1920s, the late 19th century. Very elitist, very a view of medicine, kind of mechanical, right? You learn the basic science, you learn the nuts and bolts, and it's like a machine, and the physician is a scientist type deal. And Flexner was opposed by Osler. There are actually very interesting correspondence between William Osler and Flexner, and Osler was really appalled by what was going on, and he was hoping for a continued apprenticeship, a better apprenticeship that maybe was available in many of the proprietary schools, but there was a fundamental difference of opinion. Where do you stand on that? So you're a scientist. You did very well in science, and you've benefited, and there have been benefits from subsidizing science in the way it's happened since Flexner, right?
So here, this is a very important philosophical framework, and it's a very important philosophical discussion. What Flexner did was he transformed medicine and physicians into an elitist profession in every sense of the word. It was a monopolistic system that he created. It was a system of immense respect and trust and fame and fortune. And physicians truly had a almost divinity status in their communities at the time. Now, there was nothing real about this. It was all artificial.
Right.
Elitism was not enlightened. But if any physician who remembers that time and now looks at what medicine is like, says, oh, I remember the old days when I was part of the elite.
That's right.
And life was wonderful, and people respected me, and people, called me doctor, and they gave me special driver's license, and they gave me privileges. They told me I didn't even have to serve on juries. If I was speeding, a policeman would not give me a ticket because they thought that I was rushing to an emergency. That elitism was entirely artificial. And anyone who remembers medicine in, quote, the heyday, remembers only the artificial elitism.
You're absolutely right. It was a huge subsidy of social capital.
That's right.
Given to the medical profession.
That's right. And it was not deserved. And by the way, a lot of physicians who probably could have handled that respect more tastefully and more selflessly, didn't do that. They said, if you're going to shower me with all of this money and all of this attention and all of this respect, I will take advantage of it.
Right. It's hard to resist, and it can be subconscious in many ways, right?
It's not even subconscious, it's seductive.
Right.
So
it's very conscious. I mean, how would you like to go from being worshipped every single day of your life to simply being just someone else who has to, fill out forms and work for a business? And so what we have seen during the Flexner era, which really lasted only about 60 years, the Flexner era was the anomaly.
Right.
And people don't realize that. The Flexner era from 1920 to 1980 was the anomaly. It was a special time when enormous amount of social capital was granted to physicians, and that time is never coming back.
So what would you say we should do? What would you tell the chairman of medicines who are, sitting in these positions right now, who are focused on increasing the number of year-to-year outpatient ambulatory visits, or what? How would you inspire them, or is there something else to tell them?
The most important thing is no one should become chairman of medicine. Okay, and to tell you the truth, most people who become chairman of medicine are insiders who are appointed from within because they're not demanding a lot of resources. They would like the title of chairman of medicine, and they're willing to listen to the leadership of the health system and drive their faculty. That's not a job anyone should want. That's not a job that one can enjoy. That's not a job that puts forth a role model. There's no education. There is no concept of standards. All the chairman of medicine is now is an intermediary between the health system and the faculty. And frankly speaking, unnecessary intermediary.
It's a boring job too. I see. Right.
Oi.
Well, it's very bleak. I mean, you're not giving much hope here, but that's the way it is. At least we're very happy that you're perhaps because you're out of academia now that you can be so blunt about it. It's
everyone who I speak to in academic medicine feels entirely comfortable with the accuracy of the description that I have given you.
Yeah.
Right.
Yeah.
Right.
Well, let's say, so the hope is that, perhaps we are at a breaking point where in the future, this consolidation that's happened in terms of hospitals employing physicians, my hope is that will reverse itself because
I'm sorry. It reverses itself to go back to what?
No, to go back to private physicians.
To go back to the Flexner report?
No. Well, not the. I mean, I guess it's a different time, so you'll never go back to that. But it'll go back to hospitals if we create a world, or if the environment allows it, hopefully, where we don't have hospitals employing physicians. I don't know what that'll do for medical education and whatnot, but certainly that will make health systems less powerful in terms of controlling physicians if we get autonomy.
Let me ask a question. What political force, what social force can you possibly imagine that would cause that change?
Well, further declining reimbursement. So if people actually cut the continue to turn the spigot off,
people just you're like mice on a treadmill. You just go faster, 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 faster. No. That's not going to be a problem. And if you feed the mice less, they'll go even faster.
Well,
so this is not a problem.
Yeah, but hospitals have a game that's rigged for them, right? They have certificate of need laws that prevent competition. They rely, hospitals function right now on prices for testing, for imaging, for procedures that are multiples of what they could be elsewhere, right? So if the government starts changing some of these, starts singing a different tune just because there isn't enough money anymore.
Are you suggesting that the government has the will to make these changes?
My co-host is very naive.
I recently attended a great meeting that takes place of clinical trialists in cardiovascular disease in Washington. It takes place actually at the French Embassy in December, first week in December. And it brings together trialists, academia, industry, payers, regulators, the entire research community, and most importantly, it brings in patients. It brings in patient spokespeople who come in and listen and comment. And during the last meeting, I asked the patient, are you happy with the medical care that you're getting? And the patient said, no, physicians don't spend time with me. They don't explain anything. I don't know if I'm getting good medical care. I keep on thinking that what physicians are interested in is what's good for physicians and not for me. And so then I asked the patient, just suppose the government were to say, we are going to create a major social change. We are going to reinvent medicine. We are going to reinvent medicine based on a European model. And it'll have aspects of socialized medicine in it. It will have price controls. It will motivate and incentivize physicians to spend time with patients. I said, if a politician said that during a campaign, would you vote for them? And the patient said, oh, it sounds awful. It sounds like socialized medicine. No, I'd much rather be ignored. And I'd much rather be viewed as a commodity.
But they'd be viewed as a commodity no matter what. They'd be viewed as a commodity whether it's single payer or the mishmash of payers that we have right now. Because I don't see in Europe that they're not viewed as commodities any less than we view them as commodities here.
Here's the problem. The healthcare, the financing of healthcare in the United States makes no sense. It spends an enormous amount of money to deliver a suboptimal outcome. And if you tell people, voters, that they can fix it, they won't do it. They won't.
Well, what do you make of the at least the apparent popularity of Medicare for all and single payer and all that? I mean, it seems.
Remember, I live in the state of Texas.
Right. Right. I live in San Francisco.
So if you tell people, gee, Medicare for all, a single payer system, would address a lot of the inequalities that currently exist and could raise the standard of care for everyone, there is not a lot of political traction.
Michelle, I think we have. I didn't realize we had Bernie Sanders on our show. No, this is a very good. No,
right. I sense a contradiction here, Dr. Packer, because it's the European model that got us into this mess to begin with. 100 years ago. Why keep following the European model? Why not go back to the American model, the way it was before the 1910s? Which I think is a little different from what you've the way you've described it.
Go back to the American model in the 1850s?
Yes, because if you look at historically, well, you're laughing, but when was the Mayo Clinic created? The Mayo Clinic was created in 1870. The Hopkins Hospital was created in the 1800s. The Brigham and Women's, they were very good hospitals, and the proprietary medical schools that you're talking about were actually going out of business before Flexner. That's actually quite well. They were. Things were getting better. Everything was getting better, and if we, there was no reason to change it. So, as you said, what the change by Flexner was to grant a monopoly and to centrally plan the system.
But Michelle,
there's no political will. I agree. I mean, if you're saying that there's no political will, yes.
I don't have the power to go back 150 years.
Right. No, I agree. But at the same time, I'm not sure that's moving forward to the European model of a single payer is necessarily going to be an improvement. I mean, that's not all that clear to me. It's easier to comprehend, but it's not necessarily, at the end of the day, going to be all that much better.
Let me say, my position should not be viewed as being a specific advocate for single payer or Medicare for all. That would make what I have said that oversimplifies what I'm saying. That I think the situation is really complex. But in essence, one needs to find a way to incentivize a physician-patient relationship that serves the patient.
Yes, and only the patient can do that. And any third party involved, it messes things up, whether it's the licensing, the government granting a license, or the NIH funding the research, or
so until all of the voters decide that they want physicians to pay attention to them, then the world does not change.
That's true. That's true.
All right,
and so long as the money continues to be there to fund this crazy system, the voter will continue to vote for more of this craziness, unfortunately.
By the way, the thing which is, of course, most likely is that it will become more expensive. We will spend less time with patients. We will be unhappier. Patients will get less good medical care. Medical students will not be well educated. And the world will only become an exaggerated version of what we have now.
I agree, except that there's a glimmer of hope it's a small trend. It's not very significant at this point, but if it gathered steam, it might be helpful of doctors actually saying, I'll take a pay cut. I'm going to go and deal with patients directly. Or at least I'll take a risk, not necessarily a pay cut. Some of them do take a pay cut when they do that. Others do well. But there's the development of that direct relationship with patients that is hopeful.
Here's the problem. But in order to do that, physicians have to go back to thinking of medicine as being a calling and not a job.
Right. Absolutely.
But many physicians now think of it as a job and not a calling.
Right.
That's
true. But you know, the hope is that the patients actually will be able to tell the difference between the physician who views it as a calling versus the one who views it as a job.
But the physicians who will view it as a calling will be poor.
Yeah. But if it's a calling, then it's a calling.
The question is, which physician is raising their hand and stepping out of line first?
Michelle. So Michelle, I don't know if you know, Dr. Packer, Michelle has unplugged himself from all third-party payers. He does not take Medicare. He doesn't take Blue Cross. He just deals directly with the patient. So you have somebody amongst the three of us, at least, there's one person who views medicine as a calling. So
right. So I'm not the only one. I'm certainly, as a cardiologist, I'm a lot poorer than I was when I was accepting Medicare and so forth. Many internists and primary care physicians are doing that, and some of them seem to be doing actually quite well. But certainly better than the way they were at the bottom of the pecking order. And now they're doing it. Yeah.
Remember where medicine is going, and this actually relates to what my blog is for this coming week. Medicine is moving to a point now where there will be two types of physicians. There will be physicians who do procedures.
Yes.
And there will be no one else. Because physicians who don't do procedures can be replaced. They can be replaced by non-physicians. They can be replaced by computer algorithms. They can be replaced by artificial intelligence. It is very easy for a computer to order a whole host of biomarkers and make a diagnosis, and you do not have to have a human being doing that, especially if that human being is expensive.
Right. But even physicians, even physicians who do procedures can be replaced and are being replaced. PAs are being trained in doing cardiac catheterizations, and then robots are doing procedures that's, So I think the writing is on the wall. And there are probably, the other thing we haven't touched on, but with this bubble, this immense bubble of the last 30, 40 years, the number of physicians now, contrary to how it was immediately after Flexner, where there was a dearth of physicians, now there's a huge surplus, and it's unsustainable. And the income of physicians is going to come down.
Which, of course, is very funny, because there are more and more medical schools that are being started to train more and more physicians.
Right, for free.
People say that there is a physician shortage.
Right.
And in 10 years, there will be a physician surplus.
It's absolutely.
Well, because, as you know, in many European capitals, people with medical degree drive taxis.
Yep.
And they'll be driving Ubers here. It's an improvement.
Yeah. that day is coming.
You get more interaction with your client when you're a taxi driver than when you're a physician.
Well, I'm sure Medicare will make that a billable code at some point. Uber physician, taxi driver, and I'm sure there'll be a 9922 something code. So, well, this has been a wildly entertaining conversation. It's been incredibly wide ranging. So, really fantastic, Dr. Packer. I want to give you 2 minutes, maybe less, to talk about something that a lot of our viewers, I'm sure, will be very interested in. Your views on social media, specifically Twitter-based medicine, and what you think about the Twitter all-stars.
Yeah, remember, Anish, I write a blog every week.
Yeah. No, yes, you're very much on social media, yes.
So I'm on social media, and so I have embraced social media completely, and I am amazed by its reach, its power, and its ability to shape thinking. It's unbelievably impressive. But I think your question really wasn't about social media. Your question was about Twitter.
Yes.
And Twitter is nice.
People suspect that you're lurking under a
Yes.
false identity on
We
Twitter.
want to know, what is your...
Because
No, I don't have a Twitter account. I'm sorry. And I don't, the only time I know what's going on Twitter is that I have friends who have Twitter accounts who send me snippets on email. Here's the problem. And it's not a problem that has to do with medicine. It's a problem that we see every day in politics. People say things on Twitter they should never say out loud to anybody. There is a definition of adult behavior, which means that you don't act on every thought that you have, and you don't reveal every thought that you have. That most of your thoughts are actually pretty irrelevant and are not actionable. But on Twitter, they become a permanent part of the universe.
that's true.
So anyone who wants to make their irrelevant thoughts a permanent part of the universe is welcome to Twitter.
On that note, Dr. Packer, we're gonna leave it there. We still, for the little guys like us, Twitter actually has been very helpful because it's in a way, so far perhaps we've been able to control our frontal lobes and not put out every single thoughts in a tweet, but it's been helpful for us to engage with with academics that we wouldn't have engaged with before. Otherwise, it would have been waiting our turn at the microphone in front of a podium and to ask a question and so forth.
So it's a double-edged sword in terms of this democratization that's happened. So so you can have a lot of different views that are now aired in this marketplace of ideas. But certainly, as you're pointing out, I think you're touching on the fact is that it becomes harder to gauge what the veracity of these ideas are. So there's some random person on Twitter saying something, and there's another random person on Twitter saying another thing, and it becomes hard to balance the scales, I get.
Let me suggest Twitter has an enormous potential for good.
Yeah.
Enormous potential.
Yeah.
Okay. And what you have said is, well, okay, you go to a meeting. In the past, if you had a question, you went up to a microphone and you asked. Well, most meetings now are programmed so that there are no questions from the microphone. And, so someone gives a presentation and right afterwards escapes. And there's no feedback. There are no questions. That is really frustrating. That the audience deserves a much more of someone's time than they're getting right now. Here's the problem with Twitter. Those people who are presenting, they're not on Twitter. So Twitter doesn't solve your ability to reach them. Twitter reveals the frustrations that people have. But it isn't yet a solution. Now, could it be one? I think it could be one. But we would have to change the way people think of Twitter and how they use it. All
right. Well, we will end on that note, Dr. Packer. We'll have to have you back. We didn't make it to another excellent blog of yours. And you're already writing another one, so we're hopelessly behind.
Every week.
Yeah, I know. We'll have to definitely have you back on a recurring basis to chat about some of this stuff.
I would be delighted. It would be a privilege.
Thank you so much. All righty. Thanks again.